Okay, so
Okay, welcome everyone to this Biomedical Research Center Exeter seminar series. We have 3 exciting talks for you this lunchtime, and after the talks there will be lunch outside. So please stay around to interact and discuss with each other. Before we start, I have just to go through some housekeeping aspects. So fire exit back via the main entrance to the rails or out to the lecture theatre, turn right through the double doors. There are no fire alarms kind of tests expected. The nearest toilets are just out of the lecture hall to the right. I mentioned the lunch, which will be served after the seminar. And just to let you know that we will be recording this seminar. That's all housekeeping wise, and I forgot to say who I am. I'm Adelia Warris. I'm Director of Training for the Biomedical Research Center. So it's a pleasure to be here and to introduce our first speaker. Our first speaker is Marianne Hollyman. She is a consultant bariatric and benign upper GI surgeon at Musgrove Park Hospital and a consultant researcher with the Exeter BRC. And she has a particular interest in snapshot cohort studies, leveraging them to generate foundational data that informs the development of research questions for future clinical trials. And her work primarily focused on advancing care within the field of emergency general surgery. And today she will be just talking to us about optimizing care, improving patient pathways in pancreatitis management. So over to you, Marianne.
Sorry, yeah, okay, that's good.
Yeah.
Okay, thank you very much. Thank you for the introduction. So yes, I'm a simple surgeon. I come from Somerset. I'm not originally from Somerset. I'm from Scotland, as you may tell, but I live in Somerset now. And as a trust, we feel very honoured to have been included in the BRC to give us the opportunity to develop some of our research in a more formal setting. So I've kind of, up until the last year while I've been involved in the BRC, I've sort of described myself as a hobbyist researcher. I would just do things on, with no money in my free time. And I'm hoping, and most of the stuff I'm going to talk about today is either come from that or we're at the sort of early stages of seeking funding. So I haven't got, massive grants and loads of results at the moment to show, but I'm hoping this is maybe a bit of a sort of speed dating event where I can show you what I might be interested in, and maybe some of you might come up and say that you can see some synergy between our research and see how I can take that forward with the team in Exeter. So I'm going on the assumption that most of you haven't got a particularly strong medical background, so I'll just go through some of the basics of pancreatitis and then what we're hoping to do within that area. So the pancreas is a gland, part of the digestive tract. It's got 2 main functions. One is to produce insulin to help with our glucose control, and one is to produce enzymes that helps with digestion of food. Most of the time, most of us probably don't think much about what our pancreas is doing until it becomes a problem. And because of the position of the pancreas, which is sort of surrounded by the first part of the small bowel with lots of important tubes such as the bile ducts, blood vessels, etc. around it, it's basically a very difficult organ to access and to deal with when there is a problem. So in the case of acute pancreatitis, it's sudden inflammation of the pancreas. This is opposed to chronic pancreatitis, which is chronic fibrosis. So acute pancreatitis will occur when enzymes have been activated prematurely. So the enzymes that are meant to be digesting your food are activated within the pancreas itself rather than within the digestive tract, and the pancreas basically starts damaging itself. So one of the difficulties with pancreatitis is it can actually really affect anyone. So it's quite difficult to find a specific target group of patients if you're wanting to do anything to try and prevent the disease in the first place. It is a really common condition that I will see certainly multiple times a week, if not daily, if I'm on call for surgical emergencies. So we do have a good volume of patients being affected by this disease, but it basically can affect any age. I think the youngest I've seen is a 4-year-old, and we've had a patient admitted yesterday in their 90s. So it's a really broad spectrum of disease. Very occasionally, there can be a slight familial cause. So in exceptional cases, you may be able to identify people because other people in the family have had pancreatitis, but that's not the majority. So any of you that have had a medical background, this is one of the acronyms that we used to have to learn at medical school of I get smashed to remember all the different causes of pancreatitis. So one of the different, one of the difficulties in, again, studying this as a disease, there's so many different things that cause it. So gallstones, the second one down, probably is the cause in the UK for about 50%, or at least 50% of causes of pancreatitis, and that's when the gallstone itself falls out the gallbladder, down the bile duct, and obstructs the flow from the pancreas. Ethanol, so alcohol consumption, accounts for maybe about 1 in 5 cases in the UK, which means that pancreatitis can be stigmatised because people associate alcoholism with developing pancreatitis. So this can cause quite a lot of distress to patients when they're continually asked if they've been drinking too much, got an alcohol problem. The top cause, idiopathic, is basically that we don't know what's causing it, and that's actually around 20% of patients as well. So there's a group of patients that we haven't really got a clear cause for. Lots of the other ones are less common. Lipids can be a problem in a small percentage of patients, and there's various other things we do to patients, like give them certain medications to cause pancreatitis. But it means that the patients coming through the door can be from a 22-year-old female who's developed gallstones to a 55-year-old male alcoholic, and a whole plethora of people in between, including people who've had a scorpion bite from Trinidad that causing the pancreatitis. So again, it makes your patient group quite diverse. With pancreatitis, the reason that we are very interested in it as clinicians, or worried about it when someone is diagnosed with pancreatitis, is it can be incredibly severe and in fact life-threatening. So around 2 to 3% of patients will not survive their episode of pancreatitis. Those severe patients will end up with persistent organ failure, be on HDU. I've had patients in hospital for over a year with this condition. The patient I'm thinking of luckily did survive and went on to lead a good life afterwards. But it can be incredibly debilitating disease for some patients. In those more complicated patients, they can have necrosis of their pancreas and systemic organ failure. But luckily, in the mild group of patients, the mortality rate is extremely low, and that less than 1% only in sort of the older, frailer patients where something like a heart attack may happen as a result of the disease process. So anyway, so that's a background on pancreatitis. So the initial sort of SNAP cohort study that I did into pancreatitis to try and get some baseline data in the UK was Panc Study, which we ran around 4 years ago. So this sort of study, I just approached, in the end, it was 111 hospitals to collect data for me without any funding, and they collect data on all their patients coming through the door over a 2-month period with just 30-day follow-up. 30-day follow-up isn't ideal in this patient group because, as I've said, some patients will stay in for over a year. But in terms of if you're asking people to do this in their free time, they're not. You're going to get pretty poor data collection many months in. So we just need to keep it sort of short and snappy. So it's just an idea of the distribution of centres that collected data. The majority, 87, were the sort of standard DGHs like Musgrove or Exeter, and 24 were major pancreatic centres who maybe had more of a specialist interest in this. I've just put this slide up to give you a general idea of the fact it's a relatively diverse population. It's an equal split male to female, although more likely that you've got alcoholism in the male group and the gallstones as a cause in the female group. Reasonable percentage, about a quarter, are smokers. There's a reasonable percentage, again, 20%, who have frailty. This is also a condition that affects people in the maternal and the postpartum phase, and actually several of our young deaths, unfortunately, are in mothers in the first year of life. So this is potentially an interesting group to look at as well. Patients are normally diagnosed by a blood test called amylase or lipase in some cases, if you've got, the hospital's got enough money to do a lipase test. But actually that test isn't necessarily diagnostic. In a fifth of patients, and in 1 in 10 patients, the amylase was completely normal when they came in. So we had data on 2,500 patients. I think the key points for it, when we looked at the severity for the patients that came through the door. Actually, you can see that the percentage of patients that were classed as severe was actually incredibly small. It was only about 5% of the whole patient group. So most research in pancreatitis is trying to look at this severe group, which is understandably an important group, to identify which patients are going to be when they come through the door, and also treatment that we can give them to try and prevent that severe disease, which can potentially lead to death. Overall, the treatment of pancreatitis is, or patients coming through the door will have abdominal pain, like 10 out of 10 abdominal pain, and feel incredibly unwell. The mainstay of treatment is us giving them painkillers, us giving them fluids because they're dehydrated, because the pancreas sits behind the stomach. They will often need nutritional support, but other than that, we don't have anything that we can clearly treat the pancreatitis with. So a lot of focus is on how to treat that severe group, but actually you can see the vast majority of patients are in the mild or moderate group, and actually maybe I felt by doing this study that we needed to focus on them and improving their patient pathway and care. So some of the main summaries from that large data set from the PANC study was that overall there was only a small number of patients that were severe, and overall the mortality rate was low. So I'll get onto a graph of the admission data, but virtually all patients were admitted to hospital. There was only less than 1% of patients that were managed in an ambulatory fashion, and the median length of stay in the mild group was 5 days. So actually we've got a reasonable burden on the hospital of lots of patients coming in every week needing to stay in hospital for an average of 5 days. If they're not going to develop into the severe group, do they need to stay in hospital that long? One of the other issues, as I mentioned, pain is a really big issue, and virtually everyone will get morphine as they come through the door with this condition. There are multiple reasons why opiates may not be the best treatment. There are lots of side effects of opiates, including feeling sick, which you may do with this condition anyway, constipation, feeling disorientated, and in addition, opiates can cause muscle spasm. And basically, if, for example, you've got a gallstone that's gone down the bile duct and caused a blockage, causing the muscle at the bottom of the bile duct to spasm probably isn't going to help that patient's condition. So we may be doing the wrong things for patients, and our data showed the majority of patients were having opiates. So NSAIDs, which we'll discuss in a moment, were only used in about 1 in 20 patients. A large number of patients were classed as idiopathic, which means that we haven't found a cause, and that's something else to potentially look on. And overall, there was a lack of standard of care. So that was kind of the baseline data to try and identify areas where we may want to look further. Alongside this, I've been involved in the James Lind Alliance Priority Setting Partnership on Pancreatitis, where we've identified the top 10 priorities between patients and clinicians managing pancreatitis. I won't go through them all, but we can see the top one there is, again, looking at other alternatives to opioid painkillers, because, again, this stigmatizes patients if they're needing to take opiates. It sees that they've kind of potentially got drug-seeking behaviour, etc. And there's obviously a lot of negative connotations around needing to take morphine. So patients thought that was one of the top priorities to look at. So I'll just pull out a few sort of projects that are then leading on from that initial work. So the first question that we generated from this work is, do all patients need to be admitted to hospital? Interestingly, this came from an informal sort of PPI kind of chat where I met another surgeon who hasn't got a specific interest in pancreatitis, but did have pancreatitis herself. And she told me when she thought she had pancreatitis, she got her husband to drive to the hospital, get some blood tubes, drive them home, take her blood and take them in, and blah, blah, blah. Anyway, ultimately, she got a diagnosis of pancreatitis, was managed at home because she had somebody sensible at home with her. So she suggested, actually, are we needing to admit everyone, because she knew that she'd managed to manage herself on 2 separate occasions without admission to hospital. And the data showed that basically nobody was being managed at home. So the data from the PANC study, so as I said, it's well less than 1% of patients had no night's stay. The mode is probably actually about 3 nights, but because there's such a long tail here, the mean is about 5 nights in hospital. So can we do anything to actually improve the patient experience, not necessarily need them to be admitted to hospital, not necessarily then be put on morphine? Patients will end up being potentially, my mouth, all these different consequences, and patients can come into harm in hospital, developing chest infections, patients fall out of bed, fracture the hip, all these other things. So actually, if we can manage patients at home, it may be a much better experience for the patients. So we've set up ambulatory pancreatitis pathway, which we have trialled with ourselves in Somerset, and the team in Leeds, which is the largest emergency surgical trust in the country. And we've initially done a literature review, identified a validated way of potentially identifying those less severe patients. We have then basically done an algorithm where the clinician will go through, identify which patients may be appropriate for discharge. We've given suggestions which have included giving NSAIDs rather than opiates to manage those patients, and then to discharge them, ideally coming back with a review in 48 hours to check that the patients are well. Our initial data from that, I think at Taunton have managed to do better because we've got a smaller team, so people are more in tune with this. But at the moment, we are working on having managed ambulatory around 40% of patients. So basically going from nothing to 40% is quite a large impact. And we're talking about overall there's 20,000 patients probably admitted at the moment with pancreatitis each year. So we're in the process of working with a set of other sites, around 10 sites around the country, to see if we can roll this out as a potential pathway to help manage patients. And alongside that, we'll move on to some of the other areas where we're trying to work out a way of supporting these patients better with follow-up. So although we may not want to admit them all to hospital, the problem is once they are admitted, they're in for 5 days, they're sent home, and then there's no follow-up for the majority of patients. So a lot of patients feel quite alone after that, and if they are experiencing problems, they find it quite difficult. So we've touched on non-opiate analgesia and acute pancreatitis. So as we said, NSAIDs are being used in only 1 in 20 patients. It's uncommonly used. So one of the causes on that I get smashed algorithm is ERCP, which is endoscopic retrograde cholangiopancreatography, which is basically a procedure that is relatively commonly done in most trusts in the UK if there is a blockage in the bile duct. One reason for a blockage may be gallstones itself, so it sometimes is done as the result of someone having pancreatitis to clear the blockage. But it can be done for multiple other reasons, potentially risk of suspected cancer, etc., in patients. So with ERCP, we're in a kind of a unique situation where, unfortunately, this test can actually cause pancreatitis. So this is a group of patients where an intervention can be done before the patient develops pancreatitis to try and prevent it. And this is not my work. This is just a published meta-analysis of ERCPs, but basically by giving rectal NSAIDs, so a medication called diclofenac, to patients at the start of their procedure for ERCP, they've shown that they can statistically significantly reduce the rate of pancreatitis in this group of patients. So again, there's more evidence to support that NSAIDs may actually be beneficial for our patient group, even though they are not being used routinely. So alongside that, I'm doing work with a team from around the country. It's with Aberdeen trials unit with the CI in Newcastle, but we're looking at how we can perform a randomised controlled trial on using non-opiate strategies instead of opiates in pain as a pain relief for acute pancreatitis. There are a lot of challenges with managing to, well, firstly, what the outcomes for this trial are, but also delivery of this trial in the emergency setting, because we basically need to capture patients as soon as they come through the front door. So we're still in the working this up stage. It may well be that we're originally hoping for around 30 sites for a full trial, but we probably will need to run a pilot in a handful of sites to make sure that this is a feasible study to be able to run. But I think it's incredibly important, and it, again, in terms of the funding for this, we'd be looking at some mechanistic work around understanding the differences in the process in the patients that are taking NSAIDs rather than the opiates. But anyway, we're at the sort of early stages of developing this into a pilot study. So I'd be interested for anyone's thoughts on this. So then, as I mentioned, so patients are often, although they're kept in hospital, most are discharged without any longer term follow-up plan, especially those who've had a more complicated course in hospital, can really suffer at home and feel that they don't have any support. So along with this is with a team from Birmingham. We've applied, we're just waiting to hear from HSDR at the end of the round 2 of application for a study called Panorama. We're looking at multiple work packages to basically work with patient groups to understand their patient experience. We're going to be doing a longitudinal study over the year from diagnosis to end of their follow-up at 1 year to understand how well their follow-up is being carried out, how much it affects their mental health and psychological problems alongside this. If we're successful with the funding for this as a more psychological programme, we would hope to apply for additional funding to collect some samples to biobank at the time points that we're bringing the patients back. Discussions are only just starting about that because we're waiting to hear the results of the initial application with this. But I think this would be a really great opportunity. Again, we're looking at probably 30 sites to collect patients from. It would be fabulous to be able to get those blood tests for potential biomarkers and genomic analysis in those patients. So one of the other things is the causes of pancreatitis. Some of the anxiety around patients is not knowing what the cause of their diseases, and obviously there is a risk that pancreatitis comes back. I didn't highlight it, but on the first slide of basic results, actually around 1 in 20%, so 1 in 5 patients will have recurrent episodes of pancreatitis, is necessitating it as it stands currently for them to come back and be admitted to hospital again with the potential risk to life. So if we can do anything to remove the cause of pancreatitis, such as gallstones, we would offer an operation. So the question is, are we leaving too many patients without a cause for their disease? And this is something that we should be treating. So we are looking initially locally, but applying for a PhD student to help support this work in terms of standardising pancreatitis follow-up, and also then trying to identify whether or not we've done a full battery of tests to identify a cause for their pancreatitis. There can be high calcium, hyperlipidemia, sometimes gallstones aren't picked up on ultrasound. We need to do more invasive tests. So we're looking at what we can do for best practice, whether or not actually implementing this affects patient outcome and quality of life for those patients. And again, we would hope with the funding for biobanking in these pancreatitis patients, we could do this alongside. So just to highlight again, these are only the things that we're starting the ball rolling. There's lots of other things in this field that could be explored. We do a lot of CT scans in pancreatitis. We probably overdo this. How can we rationalise the imaging of patients and again make clearer pathways to stop the burden on the NHS and the patient for coming back for lots of scans. The diagnosis of gallstones disease, ultrasound is good in a large number of patients, but it does not pick up all small stones in all patients. So those pathways need to be assessed further. There's more can be done on managing patients when they're in hospital to expedite their discharge and again make sure that they are being fully investigated. So within within the Panorama study where we're bringing patients back, we really need to look, because these patients, if they have damage to the pancreas, they can become a diabetic and they can have pancreatic insufficiency. Those things aren't commonly tested. We don't even understand what percentage of patients develop diabetes following pancreatitis or have pancreatic insufficiency. So I think that work needs to be done alongside Panorama, which again, we need to get funding for. And 50% of patients have gallstones as the cause. In that 20%, patients we don't know the cause, there may be a role for cholecystectomy to prevent further cases of idiopathic pancreatitis, and that's something else that would be great to work up into a study. So I'm aware I'm over time, so I'll just do incredibly quick adverts because, as I said, there's a bit of a speed dating event just to let you know other non-pancreatitis projects I'm a bit involved in. So I'm involved in both Floella and Camelot, which are looking at emergency laparotomies. Floella is goal-directed fluid therapy to try and reduce mortality in emergency surgery. Camelot is using rectus sheath catheters versus a sham for pain control after emergency laparotomy. We have Rosier, which is whether or not patients need to undergo a cholecystectomy after ERCP to clear their bile duct, which has been funded and opening later this year. There's also a large RCT in bariatrics called Biband Sleeve that I'm working on funding for the long-term follow-up study. So the original study has shown that gastric bypass is superior at 3 years to both a band and sleeve in terms of weight loss and quality of life. But we need to understand the long-term outcomes in patients undergoing bariatric surgery. The patients will be around between 6 and 13 years post-randomization, hopefully in that follow-up study. And also, I'm pleased that Anna Marie Toth has just been successful in starting a PhD this month in hypnotherapy in post-operative pain relief. So we've got Jan Voller, myself and Richard Kyler as supervisors. And again, if anyone's interested in the area of hypnotherapy in pain, then it's interesting to talk about that. Anyway, thank you very much. I have to say I'm rubbish with my Exeter email, so if anyone wants to contact me, probably a Somerset address. I'd be very interested to talk to anyone who thinks that there is any synergy with their research. Thanks.
Maybe we can just have time for 1 or 2 questions. Yeah, questions from. Yeah.
Thank you. I found that really interesting. I wondered. Oh, sorry. Thank you, Jane Mazzoli. I'm a geriatrician. I found that really interesting, but I wondered if you could reflect on your experiences of onboarding so many trusts to contribute data and any top tips for doing that so effectively.
Okay, so I started kind of my research career in Birmingham, and I was fortunate to be around the time of the inception of something which was called the West Midlands Research Collaborative, which doesn't have the word surgery in it, but it was a surgical group. And we, as a group, managed to sort of run the first RCTs that were actually trainee-led. So it's kind of developed from harnessing the power of trainees within medicine who are all motivated to get stuff for their CVs, but traditionally everyone would be doing an audit in pancreatitis in their own trust, and you would maybe get 25 to 50 patients and maybe present it at a local meeting and at best maybe have a small poster at a national conference. So it's partly about engaging people to say, well, actually the power of this is much greater if everyone's doing the same thing in every hospital, and therefore we can actually get some meaningful data which can start generating, we need to understand what the landscape is to be able to then generate the research questions. A lot of studies that we've done in surgery recently have come from similar snapshot audits where you don't even realise it's a problem because all you see is what's happening in your own practice, and you don't realise the hospital 50 miles down the road is doing it completely differently to you. So I think I'm a great believer in sort of collaborative authorship. So with the bank study data that we've published, it was just under, I'm not named as like senior author or whatever on the actual top line. It's just Pank study collaborative, and then everyone who has collected data is listed as a co-author. And I think that really helps motivate people. And obviously you have a responsibility to turn the paper around, because you will get people messaging you saying, what's the output from this? So it's a two-way street. They give you something, but you hopefully give them something back from that.
Thank you. And yeah, as the NIHR Research Delivery Network, we're really looking at models of supporting residents to upskill through research in those models of trainees supporting research. I wonder also, you presented data saying that there weren't any people with low length of stay, but is that a bias in the data collection because you're looking at it from the hospital direction? So people like your colleague wouldn't have been in that data because they weren't admitted.
Yes, that's true. But I think, I think from my experience, as soon as I can't ever think of a time where I've seen someone that I know that's been managed at home and then has come in later on. So I think specifically with pancreatitis, because of this small percentage that are severe with a risk of death, as soon as anyone thinks there's a diagnosis of pancreatitis, you have to get into a hospital bed, but actually in the reality, the majority of patients were not doing any more than giving painkillers and making sure they're hydrated. So as long as they're able to keep fluids down and you can give them good analgesia, which if you can stick a tablet up their backside, then you can, and they're willing to have that done, you can, then actually you're better off in their own home than being stuck in a ward full of people shouting all night or people.
Yeah, and congratulations on the impact change. That's really, really powerful.
Okay, thanks so much, Marianne. We are going to move to our second speaker. Our second speaker is Jean-Claude Katte. He is a translational fellow at the NIHR Exeter Biomedical Research Center, and he is researching the etiology and pathogenesis of young onset diabetes in African and minority population. Jean-Claude, you're trained as a Cameroonian trained general practitioner, and you are holding extensive experience in primary diabetes care, and you completed your PhD in 2022 here at the University of Exeter, which also focused on examining type 1 diabetes in sub-Saharan Africa. And you are going to present to us the evidence of a novel non-autoimmune insulin deficient diabetes in African youth. Over to you.
Thank you very much. Good day, everyone. So I'm going to be presenting on this topic, which is actually a piece of research I actually started during my PhD studies here at Exeter, and has kind of evolved over time with several other associated projects. So just really to start, so type 1 diabetes, we know it's primarily an insulin deficient form of diabetes, which of course is characterized by this severe insulin deficiency or near absolute severe insulin deficiency, which comes as a result of the progressive autoimmune destruction of the cells that do produce insulin in the pancreas, the beta cells that we heard about. And we also know that type 1 diabetes can affect both children and adults. And one of the key findings of pathophysiological elements or substance that can be detected in the blood of individuals who develop type 1 diabetes are the islet autoantibodies. As we said, it's an autoimmune disease. And as you can see on this picture of the beta cells, there are different islet autoimmune markers or targets, such as insulin. So you can have insulin autoantibodies or autoantibodies against glutamic acid decarboxylase, or the islet insulin gene, that's IA2, or the ZNTA, that's the zinc transporter. And we also know that these islet autoantibodies are present in blood, and now they are used for the confirmation of the diagnosis of type 1 diabetes. Several recent guidelines do point to that, but also can be used in the pathological staging of the disease. As you can see, most guidelines now do talk of the staging of type 1 diabetes from stage 1, stage 2, and stage 3. But all of this knowledge actually around the clinical features of the disease, or even the pathophysiology or pathogenesis of the disease, is really well developed in, I'll say, high-income countries and white Caucasian populations of Europe and North America, with really very little research or really little understanding about the pathogenesis of the disease in other ethnic groups, most especially in Africa and in sub-Saharan Africa. So, but what do we really know about type 1 diabetes in sub-Saharan Africa? So during my PhD, I was privileged to carry out a narrative review of type 1 diabetes, which was published in 2023, not 2020, sorry. And some of the key things we found during this review, looking at over 60 papers published from 1980, was that around the clinical presentation of the disease, most studies pointed to a late onset of the disease over 20 years, which is different to what you would normally see in studies from high-income countries, where the peak age of incidence or onset of the disease is around 10 to 14 years. And Another key marker we found was that most of the studies reported lower rates of islet autoimmune markers, but of course we know there are lots of limitations that we found with some of these studies, including the non-standardization of the immunological assays that we use, or the usage of non-specific local population thresholds. Very few studies looked at beta cell function, so endogenous insulin secretion, or the genetic susceptibility of the disease. We know type 1 diabetes is highly heritable, with over 50% of this heritability being conferred by genes in the HLA class 2 locus, DR3 and DR4. So there were a few studies that picked HLA DR3 from these African studies, but generally the associations were really weak because of the really small sample size of these studies. But I'm going to end with one key thing, is that when we looked at the studies that have looked at mortality rate is really quite high. Within the cohort in Cameroon, as part of my PhD, I looked at mortality over 5 years, and we reported 33 per 1,000. That is quite high. In the UK, probably around 0.8. In other European countries, really fairly around 1. So even with the recent birth of many insulin provision programs in Africa within the past 2 years, we can still see that mortality remains quite high. So generally, the understanding around the disease is really not really certain. And so this is one of the reasons why in my PhD I started studying, looking at markers of type 1 diabetes etiology to really understand the pathogenesis, but also whether type 1 diabetes really has an autoimmune etiology like we see in other high-income countries. And so we set up this study called the Young Onset Diabetes in Sub-Saharan African Study, which was a multicentric cross-sectional study across 4 different countries. I actually led the primary studies that were conducted in Cameroon, where I'm from, Uganda and Tanzania, and we also had some secondary analysis of samples that were collected from South Africa. And so we included people who presented with the clinician diagnosis of type 1 diabetes, where diabetes was diagnosed at an age less than 30 years, and who were on insulin treatment. In terms of how we assessed for markers of etiology, we looked at the islet autoantibodies, the 3 routinely tested ones, GAD, as I mentioned, IA2 and ZNT8. And in this study, for the first time, we actually used thresholds for positivity that we developed in an African normal, healthy, controlled population, and which is really different from what you would see in other studies where they would use the manufacturer thresholds from the assays. And to assess for beta cells, we actually had a post-meal C-peptide evaluation. And for genetic susceptibility, we actually calculated the type 1 diabetes genetic risk score using the 67 SNP score, which was developed here by Richard Oram and colleagues in Exeter. And so as a whole, we had an overall cohort or group of participants from 3 countries, of just over 1,000, having excluded samples from Tanzania due to some quality control issues. And we've now ended up with an overall sample size, which we analyzed, of close to 900. And so when we looked at the general characteristics of the participants in our study, we see that the age of diabetes diagnosis was at a median of 15 years, with a duration of diabetes of 5 years, and a median BMI of 21.7. And so looking at the age at diabetes diagnosis and BMI, these are features that you would normally see in any young onset type 1 diabetes population anywhere else in the world. So that was really very consistent. So, but when we look at these islet autoimmune markers, which I said at the beginning that are currently being used to confirm the diagnosis of type 1 diabetes, we found out that the majority of these children and young people with diabetes from Africa actually overall bringing the three cohorts together at about 65%, did not present with any of the islet or two antibody markers. And when we looked at those individuals who had a very short diabetes duration, that's less than 1 year, we see that that proportion still stood at 61.4%, really indicating that the duration of diabetes may not fully explain the reason why we do not see islet O2 antibodies in this population, because we know with the kinetics of these islet O2 antibodies, they tend to disappear over time. Although we know research from Exeter and other places in Bristol now show that islet O2 antibodies such as the GAD and the IA2 can fairly persist for many years after the diagnosis of diabetes. And obviously, as you can see, multiple islet O2 antibody positivity was quite low, with an overall proportion of just 8.5% in the cohort. And even in those who had really short duration diabetes, less than 1 year, that proportion was just at 16.7%. So these are the three different islet O2 antibodies that we looked at. And as you can see, the GAD islet O2 antibody was the most predominant islet O2 antibody in this sub-Saharan African population. And when we looked at the individuals who were islet O2 antibody positive only, we can see that they were diagnosed young, with a low BMI at 21.2. They were mostly insulin deficient, with a proportion of close to 80% in that population. And compared to individual control, with control individuals from the different countries, these individuals who were islet O2 antibody positive had a significantly higher type 1 diabetes genetic risk score. And so these features are features that you would see in individuals who present with classical type 1 diabetes, even in high-income countries. When we looked at those who were islet O2 antibody negative, they also presented with features very similar to those who had islet O2 antibody positivity, with the median age at diagnosis at 15 years, low BMI at 21.7. They were also insulin deficient, although less than those who were islet O2 antibody positive. And interestingly, if you look at their type 1 diabetes genetic risk score, you can see that these individuals who are islet O2 antibody negative have a substantially lower type 1 diabetes genetic risk compared to those who are islet O2 antibody positive. And so this really started giving us an indication that these individuals who are islet O2 antibody negative may actually present with a completely different, phenotype to those individuals who are islet O2 antibody positive, who look like individuals who are also islet O2 antibody positive elsewhere in the world. And so overall, we looked at the general characteristics of this population, but I just want to really, if you look at the age of diabetes diagnosis, 15, 14 years, really ignore the p-value, but in terms of clinical significance, there is really not much difference between those average or median scores of 15 and 14 years. BMI was similar across both groups. And as I said, endogenous insulin secretion measured by plasma C-peptide was higher in individuals who are islet O2 antibody negative compared to those who are islet O2 antibody positive. But these values generally still indicate, if we consider the average values or the median values, insulin deficiency. So from a clinical standpoint, it seems it's really difficult to identify or differentiate individuals who are islet O2 antibody negative to those who are islet O2 antibody positive. We also found that these individuals who are islet O2 antibody negative were most likely to have a parent with a history of diabetes. And so just really to highlight that these features in those who are islet O2 antibody negative do not really point to type 2 diabetes. We did not compare these patients to individuals who have type 2 diabetes, but at an age of diabetes diagnosis of 15 years, if an individual was to present with type 2 diabetes, one would expect at that age type 2 diabetes to be highly associated with obesity or other markers of adiposity, which we did not see. we've now also used an African-specific type 2 diabetes genetic risk score across the different groups. And we see that these individuals who are islet 2 antibody negative were not particularly enriched for type 2 diabetes using this score. So, and as part of the process, as I said, the journey, we were privileged to speak to researchers from the SEARCH study in the US, that Search for Diabetes in the Youth study in the United States of America, which is actually an ongoing and really prospective study of over 20 years studying young people with diabetes in the US. And when we compare that data to individuals of Black ancestry and white ancestry in the SEARCH database, we saw that individuals who were islet 2 antibody negative, as you can see, the proportion is highest in sub-Saharan Africa compared to Black individuals in the SEARCH data set, and of course, white individuals. And when we looked at the genetic risk score, the first hand you see from sub-Saharan Africa, individuals who are young and less than 20 years, just really under 1 year of diabetes duration. If they're antibody negative, they have a substantially reduced type 1 diabetes genetic susceptibility. We see a similar susceptibility in Black individuals who are islet 2 antibody negative in the SEARCH database in the US, but we do not see that in white children and young adults with type 1 diabetes. So what does this really tell us? It means if you're antibody negative and you are from a white ancestry, you most likely still have type 1 diabetes, irrespective of the fact that your antibody test is negative. But if you're antibody negative and you are Black, for example, from sub-Saharan Africa, most likely your genetic immune and genetic makeup is not really fairly consistent with autoimmune type 1 diabetes. And we are seeing something similar in Blacks in the US, although at a much more lesser proportion than what we are seeing in sub-Saharan Africa. And so as a summary of this study, we are saying that there seems to be, there is some heterogeneity in the pathogenesis of individuals diagnosed as having a clinical type 1 diabetes in sub-Saharan Africa. So while there is a group of individuals who actually present with classical autoimmune type 1 diabetes, that proportion is smaller, because we see they have individuals who are islet 2 antibody positive, high type 1 diabetes genetic risk score, and they are insulin deficient. But there is this other group which are actually composed of the majority of individuals who are islet 2 antibody negative. They do not show this type 1 diabetes genetic risk, and they also have features, whether clinical or C-peptide features, as we have seen, which really does not suggest they present with type 2 diabetes. And so we think these individuals actually do present with form of diabetes which is non-autoimmune, which we have called non-autoimmune insulin deficient diabetes subtype. And so to conclude, I would say that classical autoimmune type 1 diabetes does exist in sub-Saharan Africa with really similar features as described in studies in high income setting, but that most of the youths, these children and young adults with a clinical diagnosis of type 1 diabetes in Africa do actually have a different etiology disease, which is non-autoimmune, but also insulin deficient. And that there is, at least from our preliminary analysis from the SEARCH database, showed that there is evidence of this atypical phenotype also in Blacks in the United States of America in the SEARCH cohort. So this study recently, we have written it up and submitted it to the Lancet and has gone into reviews. This is just the preprint page, which I picked yesterday night with over 199 views, 60 downloads. So it seems to be really a popular paper. Hopefully it goes through. And this work wouldn't have been possible if not of my PhD supervisors, Angus Wisier from Exeter, Eugene Subgui in Cameroon, and all the other host of individuals from Exeter, from the MRC in Uganda, and with University of Leeds in South Africa, and also from colleagues from Tanzania who participated in the study. But of course, the funding was from the NIHR Global Health Group, and now also thank you to the BRC in Exeter for supporting, for the continued support.
Thanks, Jean-Claude, for a very interesting presentation and study. One or two questions? Maybe I can just start off. The diabetic genetic risk score you're referring to, is that risk score validated in white population? So I think it not that surprising maybe that people from sub-Saharan Africa with diabetes don't fit into that risk score, or am I overlooking?
No, it's a fair point. Well, the 67 SNP score, however, in the US has been validated in other non-white populations, and the score also there's also a recent population about using that score in an Indian population, showing that it discriminates fairly strongly between type 1 diabetes and other non-type 1 forms of diabetes. Okay. And we also have just done that study within our cohort, showing that the 67 SNP works exactly well as well in the African population, okay, which would be a separate publication.
Yeah, okay. Oh, that's interesting to hear. Yeah, thanks. Well, then thank you again, Jean-Claude, for your. We move to our third speaker, what will be a short presentation given by Marty Frith. And Marty is a second-year PhD student funded by the Exeter BRC, and he's working in the neurodegeneration team. And his primary aim of his PhD project is to investigate the use of genomic biomarkers in the early detection of neurodegenerative diseases. And he is going to tell us about developing a novel genomic biomarker for the early detection of neurodegeneration. So over to you, Marty.
Thank you. Right, yeah, hi, yeah, so I'm a second-year PhD student here at the Exeter BRC, and I'm just going to give you like a very quick whistle-stop tour of premise of my project, what work I've done so far, and what we're going to be doing in the near future. So one of the primary issues with diagnosing neurodegeneration at the moment is that before the first presentation of clinical symptoms, there's potentially decades of neurodegenerative processes that are happening, and you get this increasing irreversible damage to neuronal cells all before the patient's ever diagnosed, which means sort of leads to problems with treatment after diagnosis. Probably explains a lot of why our treatments for neurodegenerative diseases haven't been particularly effective so far. So what we'd really like to do is sort of design a novel diagnostic test that we can deliver earlier on in disease progression. And then one potential test that we can deliver earlier on would be something called a liquid biopsy. So this is a minimally invasive test performed on a body fluid to detect cellular or molecular biomarkers to obtain diagnostic, prognostic, or predictive information about disease. So far, sort of today, the body fluids for liquid biopsies of neurodegenerative disease have been focused on plasma, urine, and CSF. And the biomarkers have been focused on proteins that are sort of associated with disease pathology. So things like phosphorylated tau protein, amyloid beta, and neurofilament light chain. But there's an issue with these protein biomarkers in that they don't really inform us what cell types are experiencing degeneration, especially at the earlier stages of disease, and therefore what disease the patient actually specifically has. So as an alternative to these protein biomarkers, we're sort of proposing a genomic biomarker based on something called cell-free DNA. So cell-free DNAs are these short fragments of DNA that are released from cells when they die, such as by neurons when they degenerate, and they're consequently found circulating freely in the blood. And importantly, these cell-free DNA fragments retain something called their DNA methylation modifications. So DNA methylation is a chemical modification, predominantly to cytosine residues to proceed guanine residues in DNA, and they generally serve to repress gene transcription. And every cell type has got its own unique DNA methylation profile that allows the cell type to transcribe only the genes it needs to fulfill its function. And therefore, this unique DNA methylation profile can sort of be used as like a barcode to infer the origin of DNA fragments, or the cell type origin of particular DNA fragments. So our idea here is that we can isolate cell-free DNA from patient plasma samples, perform some DNA methylation sequencing on that, and then use a technique called cell type deconvolution to infer the cell type of origin of different cell-free DNA fragments in the plasma sample. And if we were to detect a neuron-derived fraction, we might suggest that that patient has some sort of neurodegeneration. So to date, we've sort of designed our own novel cell type deconvolution algorithms, sort of specifically designed to handle cell-free DNA data, and to search for cell type proportions that might be quite small, such as in the case of neuron-derived proportions, or fractions rather. And from this little bar chart here, you can see it's probably quite hard to see actually, but we ran this deconvolution algorithm on like 20 samples, and it was able to detect a neuron-derived fraction in about 10 there, highlighted by that black box. So it's showing that this is sort of working as intended. It's also quite reassuring to see that the other cell type fractions are sort of what you'd expect from plasma, so stuff like white blood cells and erythrocytogenesis, which is nice. And then as an alternative biomarker, we've also been thinking about using something called hydroxymethylcytosine, or DNA hydroxymethylation. So it's quite similar to DNA methylation, but there's evidence that this particular marker is elevated in neuronal cells compared to other cell types. So you can see here we've got neurons and other brain cell types like dendrocytes and microglia. In blue is our levels of DNA methylation, and yellow are levels of hydroxymethylation. And you can see that in neurons compared to the other brain cell types there's quite an elevated level of DNA hydroxymethylation. So since these levels of hydroxymethylation are quite unique to neuronal cells, it might be possible to use DNA hydroxymethylation profiling as a biomarker for neurodegeneration. And in fact, this has been used to detect cancer and other diseases, but not yet for neurodegeneration. So there's two possible avenues, or a couple of possible avenues that we sort of identified for this hydroxymethylation biomarker-based assay. One would be the sequencing-based assay, so much like we've done already, continuing to use our nanopore sequencing platform that we're already using to detect DNA methylation, to detect both the modifications, and then sort of integrating the hydroxymethylation profile somehow to improve the ability of our assay to sort of identify patients with neurodegeneration, or alternatively using an assay not based on sequencing to possibly detect maybe enrichment of hydroxymethylation at some neuron-informative gene loci using techniques such as ddPCR. And this could be just as sensitive as sequencing, but also costs far less. And then, so just sort of what I'm going to be doing in the near future, I'm going to be developing some DNA spike-in samples. So these would be cell-free DNA samples that have got a known proportion of neuron-derived DNA in them. This would be a really useful tool for validating our deconvolution based sort of assay and any hydroxymethylation-based assay that we come up with. And then sort of the main thrust of the whole project here is to test the cell-free DNA deconvolution and also any hydroxymethylation assays we come up with in a big cohort of neurodegenerative disease patients. So that might include Alzheimer's, Huntington's disease, and ALS patients, as well as age and sex matched controls. So that's me. Thanks everybody up here, and thanks to the NIHR BRC for funding this project.
Thanks so much for sharing that with us. Exciting work. Questions?
Okay. Their environment. I think. Okay, there we go. Thank you. It sounds fantastic. Could you, obviously in your analysis, you're treating neurons as a sort of single population, and I completely understand why, but they're not. So how do you go about sort of, I mean, how do you go about dealing with that sort of heterogeneity between, in terms of what's coming out of different types of neurons, or sort of cell-free DNA is coming out of different types of neurons?
Yeah, so in terms of like cell type deconvolution, the algorithm itself is designed around single or cell type specific sequencing data. So the reference matrix has got it hasn't discriminated between different types of neurons. So anything that has a neuron-like signal, that being different populations of neurons, will sort of be pushed out of the algorithm at the end as just neurons. So there's not at the moment the ability to discriminate between different populations, but in the future, with enough cell type specific sequencing data, that's something that we like to do, or I'd like to see happen. It's quite it's limited to just neurons specifically, just neurons broadly at the moment. Yeah.
There are databases out there which look at different cell type, or different. We've got different neuronal subpopulations in terms of their, well, at least in terms of their RNA. I guess it's different. Yes. Probably in terms of the methylation data, maybe not. Maybe it's I don't know.
Yeah, that's not something I've seen so far anyway in terms of methylation data. Yeah.
Okay.
Hi, that was great. Thanks. So the hydroxymethylation in your neurons is quite striking, but do you know what the reason for that is, and are there other cell types in the body that might have high hydroxy that would kind of get in the way of your potential methods? If it's like a non-brain cell type that has high hydroxy, that could be called, that you could pick that up and then think that was a neuron.
Yeah, so I'm not too familiar with the actual function of hydroxy methylation over normal DNA methylation. I think they might be quite similar, but I might be wrong. And then in terms of other cell types that have elevated level of hydroxymethylation, again, it's something that can only really be researched using cell type specific sequencing data, using a platform that's been designed to actually detect hydroxymethylation, which there's not that many resources for. So might be something to do a little bit more searching on. It's quite a new area that we're looking at, but yeah, it's a good point. Thank you. Yeah.
A lot of studies have looked at it using different more global measures, and most tissues show very negligible amounts of hydroxy. It's known it's enriched in the brain, in brain tissue, but using the oxynanopod technique is very powerful, and we're actually surprised at how much hydroxy we're seeing in our neurons. This is from like post-mortem brain tissue, and the fact that it's distributed, it's very gene-eccentric, so it looks like it has some function. So something you can get into later. And going back to John's question,
Right.
we actually have our profiling motor neurons and other neuronal types, but for us it's just isolating them.
Yeah.
And although there's very limited single cell methylation data set, and there's no hydroxy.
Yeah.
So there's very limited information on, but that is something we'd like to do. And as we're going forward, we're trying to use some different sequence mechanics as well to look at smaller populations, because the problem with ONT is you need a lot of DNA. So that's why we've just used UN positive.
Yeah.
For our sort of atlases at the moment, but going forward, we're trying to get that down to the more discrete.
Okay, thanks so much, Marty. Before we go outside and have lunch, just a few more announcements. We have some funding opportunities coming up within the Biomedical Research Centre. At the moment, we have a pre-application support funding call out that is open till Wednesday, the 5th of February. That's for clinicians and healthcare workers or allied healthcare professionals who are fully clinically and want to have some time out of the clinical activities to focus on grant writing writing a proposal. That's an ideal opportunity we have on offer at the moment. So have a look at that if that's something you are interested in. And we will be soon launching our second call for small research project grants. So what's the website? Hopefully they will come out the end of January, beginning of February. And if you are not on our mailing list to get all the important announcements, as well as the invites or the announcements for the seminars like today, please go and see Sophie, and we are very happy to add your name to the mailing list. Thanks all for coming. Thanks to our speakers, and see you next time.
Yeah. Well, I know. Yes.
It was just one, but it was more not until you already.
You did?
Yeah.